Hello, students. Welcome to Chapter 14 Nursing Management During Labor and Birth. As labor begins, the nurse plays a very pivotal role in promoting safe, evidence based, and compassionate care for both mother and the fetus. So, this chapter here focuses on a comprehensive nursing responsibilities from assessment, comfort, to clinical decision making and patient advocacy throughout the stages of labor and delivery. So, moving on to the key terms related to fetal heart rate. First, you have what's called accelerations, and that's temporary increases in the fetal heart rate, often response to fetal movement, which is generally good and reassuring. Next, you have what's called autophagy, and that's like irregularities or distortion in the fetal heart rate. Tracing is usually due to some type of interference, usually external interference like maternal movement or signal loss. Next is baseline fetal heart rate. The average fetal heart rate over 10 minutes, excluding accelerations or decelerations and periods of marked uh, variability. Normal is 110 to 160 beats per minute. Then you have the baseline variability. This is like fluctuation in the baseline fetal heart rate measured in amplitude. It indicates fetal amniotic nervous system health. You have what's called decelerations, and that's like a transient decrease in fetal heart rate, usually classified as early, late, or variable, or even prolonged, just really depending on the timing and the shape. Electronic fetal monitoring. This is continuous or intermittent monitoring of the fetal heart rate and uterine contractions, usually external or internal devices. Next is periodic base changes, and this is temporary fetal heart rate deviations related to like maybe uterine contractions, such as accelerations and decelerations. So, in this section, we'll review the critical vocabulary that helps nurses interpret fetal heart rate tracings effectively. So, understanding these terms allow for early identification of fetal distress and guide clinical interventions during labor. So, next we have nursing management of laboring patients. First on the list is assessment. We want to monitor maternal vital signs, fetal heart rate, uterine contractions, cervical changes, and overall just labor progress. Comfort measures. Okay, so here we will provide pain medication, both pharmacologic and non pharmacologic, position changes, hydration, and a common environment. Emotional support. We want to offer continuous presence, reassurance, and promote a sense of safety and empowerment. Information and instructions. Here we want to educate the patient and the family about what to expect, procedures, labor stages, and just answer their questions clearly. Advocacy. We want to respect the preferences. We want to communicate patients' needs to the healthcare team and just really uphold patient autonomy. Support for the patient and the partner, right? So we want to support for the partner, which involves support person. This can be the doula, whoever they have there. We want to provide guidance on how they can help and address their emotional needs too. Maternal assessment during labor and birth. During labor, continuous and accurate maternal assessment is essential to ensuring both mother, which is the maternal, and fetal safety. This slide covers the key components of the maternal evaluation during labor. First, we assess the maternal status. This includes routine monitoring of the vital signs such as blood pressure, heart rate, respiratory rate, temperature, oxygen saturation. Please pay close attention to the pain levels as well, which these should be assessed frequently and managed proactively. Also, always begin with the review of the prenatal record to identify any risk factor or complications such as gestational diabetes, GBS status, or any prior cesarean birth, which can influence the labor management. Okay, so next, the vaginal examination, which is typically performed periodically or as needed based on the progression of labor. So you'll need to assess cervical dilation, effacement. What else? Let's see. Membranes, status membranes, like whether the amniotic sac is intact or ruptured, fetal descent, fetal presentation, whether the fetus head is down or presenting another body first. Always perform this examination with sterile technique to reduce the risk of infection. If there's a rupture of membranes, document the time, color, odor, and amount of amniotic fluid. Clear fluid is always good. Clear fluid is normal. However, if you see green or foul smelling fluid, this can indicate fetal distress or infection. Always evaluate the urine contractions for frequency, duration, and intensity. You can refer to your book at 14.2 to reinforce how these are monitored or interpreted, and especially when using internal or external fetal monitor. Lastly, Leopold's maneuver. This is like hands-on technique, which is used to determine fetal position, presentation, and engagement. This is especially important to use this before placing monitors or doing a vaginal exam. So this is just a position of, I think this is the nurse or the provider doing an assessment. Um, they're doing a bimanual exam, and it seems like they want to feel the cervix to see if it's dilated or not. Okay, so here, fetal assessment during labor and birth. Now we turn our attention to the fetal assessment, which is a very crucial part of the nursing care during the labor. The primary goal here is to evaluate how well the fetus is tolerating labor and to detect any signs of hypoxia or early distress. So let's start with the amniotic fluid analysis, okay? When the membranes rupture, either spontaneous or artificial means that they caused the amniotic um, membranes to rupture. So when this happened, we assess the color, consistency, and the odor of the fluid. So like I mentioned before, clear is expected, but you have something that's called meconium stained fluid. Okay, meconium stained fluid. And this may indicate fetal distress and increases the risk of aspiration. A foul odor could signal infection, like mentioned before, which will require immediate intervention. So next is the fetal heart rate monitoring. Uh, this is one of the most important and routine fetal assessment. There are several methods that you can monitor the fetal heart rate. Number one, there's like a handheld Doppler device, and this is used for intermittent auscultation in low risk labor. Then you have the electronic fetal heart rate monitor, and this can be external, like using ultrasound transducers or the Toco diamometers, or internal, and that's like using a fetal scalp electrode and intrauterine pressure catheter. So for this, will have you to have more details and continuous data. So the decision between intermittent versus continuous monitor depends on the maternal and fetal risk factors. Internal monitoring is typically reserved for high risk situations or when the external readings are inadequate. When we interpret fetal heart rate patterns, we look at several components: the baseline heart rate, which should fall between 110 to 160 beats per minute, baseline variability, which reflects the health of the fetal ANS, auto, autonomic nervous system. So moderate variability is ideal. Okay, that's good. That's ideal. Moderate. Absent or marked variability can be a warning sign. So periodic changes like acceleration and deceleration, these are described in your book at 14.1 in your textbook. Their time and duration and shape help us tell the difference between benign versus something that may be concerning, like a concerning pattern. For an example, early decelerations are usually benign and minor and mirror contractions. So early decelerations are usually benign and they mirror contractions, while late decelerations may suggest that there's something going on, maybe uteroplacental insufficiency, and require prompt action. So we have some advanced assessment tools such as fetal scalp sampling for blood pH when there's a concern of acidosis, fetal pulse oximetry to assess fetal oxygenation more directly, fetal scalp stimulation, which involves gently stimulating the fetal scalp during a vaginal exam to see if acceleration occurs. This is very reassuring and a sign of fetal well-being. So as a nurse, we're often the first to detect subtle change in the fetal heart rate pattern. Timely observation and intervention can make a significant difference in the fetal outcome. So this slide focuses on best practice guidelines for the fetal heart rate assessment during labor. These protocols help ensure that we're continuously evaluating fetal well-being and adjusting to care based on a risk level. When a patient first arrives in the labor or birth unit, we begin at 10 to 20 minutes continuous fetal heart rate assessment. So you're going to assess that when they arrive, 10 to 20 minutes. You're going to continuously assess the fetal heart rate. This baseline reading helps determine if the fetus is tolerating labor and whether the pregnancy qualifies as low or high risk. We also use this time to observe for any non-reassuring patterns that might indicate the need for more frequent or continuous monitoring. At the same time, we complete a comprehensive prenatal and labor risk assessment. This includes reviewing the prenatal records, maternal vital signs, labor progress, fetal presentation, and any known complications, such as like diabetes, hypertension, or any other previous cesarean sections. All this information will inform how frequently we need to monitor the fetal heart rate. For an example, low risk patients during active labor, intermittent auscultation every 30 minutes is generally considered safe and appropriate for these patients. However, for high risk patients, interval shortens to every 15 minutes due to the increased chance of complications or fetal compromise. During the second stage of labor, when the fetus is descending and the mother is actively pushing, fetal heart rate monitor needs to be more frequently. For low risk patients, the standard is every 15 minutes. But for high risk patients, auscultation should be done at least every 5 minutes. It's important, and I'm going to emphasize these are minimum guidelines. If there are any changes in maternal status, fetal heart rate patterns, or even the labor progression, more frequent monitors may be needed. These intervals are based on recommendation from professional bodies like AWAN and the American College of OBGYN. Okay, we have our first question here. According to these bodies, ACOG, ICSI, AWAN, guidelines, how often should fetal heart rate be assessed for high risk laboring patient in the second stage of labor? Every 5 minutes, every 10 minutes, every 15 minutes, every 20 minutes. If you answered every 5 minutes, you are correct, because during the second stage, intermittent auscultation should be done every 5 minutes for a high risk patient and every 15 minutes for low risk patient. Continuous electronic fetal monitoring. This generates a graphic record of the fetal heart rate pattern over time. The primary objective of this monitoring is that it provides information about fetal oxygenation, prevent fetal injury due to impaired oxygenation, and detect fetal heart rate changes early before they become prolonged or severe. Let's see. The graphic record helps to observe the fetal heart rate, baseline variability, accelerations, decelerations, and how pattern correlates with the uterine contraction. So once again, the primary objective of the electronic fetal monitoring is fetal oxygenation status. Since the fetus rely on the maternal blood flow and placenta function for oxygen, any compromise like cord compression or uterine tachysystole or even placenta insufficiency can lead to hypoxia, and if unrecognized, permanent injury can occur. One of the key benefits of continuous monitoring is the ability to detect fetal heart rate changes early, especially before they progress it to, something prolonged or profound decelerations, which can indicate a more serious compromise. However, as we discuss later, the EFM, which is electronic fetal monitoring, has both benefits and limitations, including a high false positive rate and increase interventions. So, clinical judgment remains essential. Okay, so this slide includes an image illustrating the internal fetal monitoring, which involves the use of two primary tools: the intrauterine pressure catheter, and the fetal scalp electrode. So let's break it down to their purpose and why they're used and when they're used. So the fetal scalp electrode is a small spiral wire that is inserted through the cervix and attached directly to the presenting part of the fetus, usually the scalp. It provides a more accurate and continuous reading of the fetal heart rate compared to the external Doppler monitoring, especially when movement or maternal um, habits interfere with the external signal. The intrauterine pressure catheter, or IUCP, is placed inside the uterus next to the fetus after the membranes have ruptured. It directly measures the strength, frequency, and duration of uterine contractions in millimeters of mercury. This gives us an objective about the contraction intensity, something external monitors cannot really assess accurately. Internal monitors is generally reserved for high risk labors or situations where external monitoring is inadequate, such as obesity or excessive fetal movement or inconsistent external tracing. These are all the reasons why external monitor may be inadequate. So it's obesity, excessive fetal movement, inconsistent external tracing. When more precise data is needed to guide the decision about labor or interventions, they may need something different. So it's important that both methods require ruptured membranes and sufficient cervical dilation. And guess what? It carries a slightly increased risk for infection or trauma. Okay, let's see. Let's move on to the next slide. Okay, this slide here outlines the specific clinical criteria that must be met before the internal fetal monitoring. Using tools like fetal scalp electrode, or the intrauterine pressure catheter can be safe and effectively performed. First and most important, the fetal membranes must be ruptured. Okay, so it must be ruptured, the membranes. This can happen spontaneously or be done artificially, but internal device must pass through the cervix into the amniotic sac. Inserting them through intact membranes would only risk injury or infection. Okay, so you don't want to insert unless the membranes are ruptured. Second, there must be sufficient cervical dilation, at least 2 centimeters. This allows enough space to safely insert the spiral electrode or catheter without causing trauma to the maternal or fetus. More dilation may be required depending on the clinical context and station of the presenting part. And third, the fetal presentation must be like low enough in the pelvis to allow safe placement of the scalp electrodes. If the fetus is still floating high or malposition, meaning like they're in a transverse lie. Attempting internal monitor could be dangerous. Finally, a skilled practitioner must be available to insert the spiral electrode correctly. This procedure requires clinical expertise to properly place and avoid complications like scalp trauma or detachment. This slide here highlights one of the most critical components in interpreting fetal heart rate patterns, baseline variability. So variability reflects the autonomic nervous system activity of the fetus. Specifically, the balance between sympathetic and parasympathetic tone. It's one of the best indicators of fetal oxygenation and well being. There are four recognized categories of the baseline variability. Number one is absent. This means there is no detectable fluctuation in the baseline of the fetal heart rate. The tracing appears flat. This is concerning and may indicate fetal hypoxia or acidosis, and it requires immediate evaluation and intervention. Number two is minimal. Fluctuation range from less than 5 beats per minute. This may be benign, maybe such as during fetal sleep, or maybe, let's say, an early signal of early hypoxia, maternal medication like opioids or magnesium sulfate, or even prematurity. It's important to assess the overall clinical picture. Then you have moderate. This is normal and reassuring. The variability is usually between 6 and 25 beats per minute. It indicates that the fetus has a well functioning nervous system and is adequately oxygenated. You have something called mark. This is a fluctuation of greater than 25 beats per minute. Now, while less common, it may be a sign of acute hypoxia, cord compress, or even fetal stimulation. Interpretation depends on the association, um, fetal heart rate patterns, and clinical context. Along with the variability, we also evaluate periodic base changes, which include A, accelerations, which are temporary increase in fetal heart rate and are generally reassuring, and decelerations, which are decrease in fetal heart rate and may be benign or concerning, depending on their type, like early, um, variable, late, or prolonged. Remember, baseline variability is often more predictive of the fetal status than baseline heart rate alone. Moderate variability with accelerations usually indicate a well oxygenated fetus. This slide reviews the three-tier classification system developed by the National Institute of Child Health and Human Development, really to standardize and interpret the fetal heart rate tracing. These categories really help physicians, clinicians, registered nurses to make an informed decision about fetal well being and the need for intervention. So, category one is normal. Okay, this is a baseline fetal heart rate between 110 and 160. Moderate variability between 6 and 25. No late or variable decelerations. May have early decelerations or accelerations. So, category one is reassuring. It tells us that the fetus is well oxygenated with no immediate risk. We continue routine monitoring. Category 2, intermittent, includes everything that doesn't meet the criteria for category 1 or 3. Examples: minimal variability, tachycardia, bradycardia, without absence of variability, um, absence of acceleration after stimulation, and variable decelerations with slow to return to base. This category 2 is a gray area. It's not clearly reassured, but not clearly abnormal neither, right? So these patterns require continuous surveillance and clinical judgment and may be transient, while others may signal early compromise. Then we have category 3, which is abnormal, just abnormal. This is absent variability with reoccurrent late decelerations, reoccurrent variable decelerations, bradycardia, or a sinus sonodial pattern. Category 3 is non reassuring and abnormal. These traces are associated with fetal hypoxia or acidosis. Immediate evaluation and potential intrauterine resuscitation and possibly delivery are necessary to prevent injury or death. So, as nurses, it's very important that you document accurately and you communicate fetal heart rate patterns and changes in a category to the provider. Prompt interventions are based on these categories, um, can improve fetal outcome and even reduce complications. Okay, so here's some more. This is in your book. You can read this at your time. It just different, more interventions for category 3 um, patterns. Okay, so let's see. I'll just give you the highlights. Position change. Reposition the patient to the left, to the right. Lateral knee to chest, hands and knees position to improve. So, just to recap, the patient can turn to the right or the left. She can put her knees to her chest, hand and knees position to improve this uteral placenta blood flow. Discontinue oxytocin, pitocin. If the patient is receiving like oxytocin, stop it. Stop the infusion and stop it so it can reduce uterine, what they call tachysystole, or excessive contractions that may compromise fetal oxygenation. Administer oxygen via 10 liters to improve maternal fetal oxygenation. Okay, you can do this in a non-breather mask, but usually typical 10 minutes. Give IV fluids, isotonic IV fluids like lactated ringers. This will improve circulation volume and placenta perfusion. Notify the provider immediately. Rapid communication is critical, very, very critical. Okay, the provider may consider further interventions like an amnio infusion or delivery or cesarean birth. So you can read that independently. Pain management is a vital part of nursing care during labor. This slide emphasizes the importance of assessing and managing labor pain and the variability options that's available to support the birthing patient through this intense experience. So, first, it's important to acknowledge that pain is a universal experience during labor, but the intensity, location, and perception of that pain varies greatly between individuals. Culture backgrounds, previous experiences, fear, anxiety, support system, and even fatigue all influence how the pain is expressed and experienced. So, as a nurse, we are legally and ethically required to perform routine pain assessment according to the national standards. Every patient admitted to a health care facility must have their pain assessed. Laboring patients are no exceptions. Pain must be evaluated regularly and interventions adjusted based on the effectiveness and the patient's feedback. So there are two major categories of pain relief. Number one, you should already know this, non-pharmacological pain method. This here includes, let's say, breathing techniques, massages, hydrotherapy, music, movement, and positioning, acupuncture, support from doulas or partners. These particularly are important in early labor and for patients who desire natural or unmedicated birth. Then you have the pharmacologic methods, and that's like systemic opioids, nitrous oxide, regional anesthetic like epidurals, and local or Purdue blocks. These are highly effective and widely used, but must be tailored to the person's health condition and their labor stage and their preference. So ultimately, it's our goal as nurses to support the labor and patient choices, minimize discomfort, which means maximizing their comfort, and promote a sense of control and confidence during the birth experience. No method or no one method is right for everyone. And so inform the patients respectfully, and individualized care is our gold standard as nurses. This slides review just a variety of non-pharmacologic strategies that can help the labor and patient manage their pain, anxiety without medication. These coping and support methods are natural, um, and they can be used along or aside the pharmacologic options. So, first and foremost, we continuous labor support, whether from a partner, doula, family member, or nurse, is consistently shown to reduce pain perception, decrease the length of like labor, and improve birth outcome. Emotional presence and encouragement makes a huge difference. So what this means is just show up and give that continuous support. Don't just come and leave for a few hours and then come back. So, tell the partner to stay by their side. And then as nurses, frequently check on them. Okay. Hydrotherapy, such as warm showers, baths, can provide a soothing relief by relaxing the muscles and promoting circulation. It's often used early in labor to help reduce pain and anxiety. Ambulation. You see, sometimes the pregnant women will walk around. Well, ambulation and position changes are critical. Encouraging patients to move and try positive positions help the fetal descent. It improves that. It improves uterine blood flow and can ease back pain and pelvic pain as well. Okay, so we have a question here. True or false? Pain is experienced by the patient. Oh, let me repeat this. Pain experienced by a patient in labor is fairly intense. True or false? If you answered false, you're correct because the pain in labor is universal. It's a universal experience, but the intensity Remember, it varies on culture, varies on fear, varies on anxiety, things like that. Okay, so this slide covers a main pharmacologic option used to manage pain during labor. These measures range from systemic medication to highly targeted regional anesthesia. So, first, let's talk about systemic analgesic, which involves administering medication, usually like opioids or other sedatives, through IV or IM routines. These drugs reduce the perception of pain but may cause side effects such as maternal sedation or neonatal respiratory depression. So, timing and dosing are two very important things. Next, regional or local anesthesia provide more targeted pain relief by blocking the nerve transmission in specific areas. For example, including Purdue blocks or local infiltration anesthesia is used during um, perineal repair. Okay, so this slide here focuses on systemic analgesia, which is a common pharmacologic method for managing labor pain. These medications are usually given parenterally, most often through existing intravenous, existing line that the patient may have to ensure rapid and controlled delivery. So the primary drugs used include several different types. Let's discuss them. So first you have the opioids and butorphanol, nalbuphine, remifentanil, and fentanyl are the mainstay systemic analgesic. So they work by depressing the central nervous system to decrease pain perception. These drugs provide effective and pain relief, but must be very carefully timed and dosed to minimize side effects like maternal sedation or neonatal respiratory syndrome or depression. Antiemetics, including hydroxyzine and promethazine, are given along the sides of opioids to manage nausea and vomiting, which is a common side effect of opioid administration. Benzodiazepines like diazepam or midazolam are occasionally used for their sedative and anxiolytic effect, but they are generally avoided in labor because of the risks to the fetus, including respiratory depression and floppy infant syndrome. So, nurses, you need to make sure you are vigilant in monitoring the mother and fetus closely after administration of these medications. Timing is crucial. Opioids given too close to delivery can depress the newborn's breathing. So coordination and OB team are very essential. Collaborate with them. Understanding the types of systemic analgesics and their effects enable nurses to educate the patients, anticipate side effects, and respond promptly to complications. Epidural block is the most widely used method, and it typically involves continuous infusion or intermittent injections of analgesic or other medications into the epidural space. Epidurals are usually initiated once cervical dilation reaches about 5 centimeters, although this can vary depending on the clinical judgment and the patient preference. And epidurals also provide effective pain relief from waist down, allowing the patient to remain awake and alert. So, a variation is the combined spinal epidural block, sometimes called walking epidural. And this is a technique that combines a single spinal injection for rapid pain relief with an epidural catheter for continuous analgesic. It allows some patients to maintain more mobility during labor. PCEA, patient control epidural analgesia, gives the laboring patient the ability to self administer preset doses of the medication through the epidural catheter, enhancing a sense of control over pain management. Local infiltration anesthesia is commonly used during the episiotomy or perineal laceration repair after birth. It involves injecting local anesthetic directly into the tissue just to numb the area before they make their laceration. The Pruno block is usually administered during the second stage of labor, especially when an episiotomy or some type of operative vaginal birth, like maybe forceps or vacuum, is anticipated. So, what it does is it kind of like anesthesializes the lower vaginal area, the vulva, the perineum. Okay. And lastly, you have the spinal analgesic or the anesthesia. Um, this is called the intrathecal, and it's used during labor and cesarean birth. This involves a single injection of medication into the cerebrospinal fluid, providing rapid and profound pain relief or anesthesia, especially for C sections or cesarean section. So each technique has indications, benefits, potential risks. So a thorough patient education and monitoring are essential for safe, effective care. So you have general anesthesia, and this is reserved primarily for emergency cesarean birth or when there are like contraindications to the use of regional anesthesia, such as certain bleeding disorders or if the patient refuses. This can be administered either IV, injection, inhalation, or even a combine of both methods. Typically, the sequence begin with an IV injection um, of the thiopental, which is a rapid acting barbiturate, and it also induces unconsciousness quickly. This is followed by administration of a muscle relaxant to facilitate intubation and prevent muscle movements from surgery. After muscle relaxation, the patient is incubated to secure the airway and provide controlled ventilation. Once intubated, um, once intubated, there's like a mixture of nitrous oxide and oxygen is administered, sometimes along with a volatile agent, and this helps the anesthesia to provide like amnesia. So this slide focuses on the critical information that nurses should gather on the phone assessment when a patient suspects labor. So first, ask for the estimated date of birth. So keep in mind, let's rewind a little bit. When the patient calls the ER, let's say you're doing nurse triage and they want to know if they should come in, these are the first things you should ask. First, ask for the EDB, estimated date of birth, to confirm the timing and assess whether the pregnancy is term. Inquire about fetal movement and how frequently the patient has felt the baby moving over the past few days. Decreased fetal movement can be a signal of fetal distress and requires prompt evaluation. You'll tell them to come in immediately. Ask about any type of signs of labor, such as backache, pelvic pressure, or bloody show. Gather OB history, including how many times they've been pregnant, priority, how many births have they given, gravida, as well as previous childbirth experiences. This information can help you anticipate labor progression and potential complications. So find out the time frame of previous labors. For an example, how long the labor lasted in their previous deliveries, and explore the characteristics of contractions. Um, are they regular or irregular? How long do they last? And what's the frequency? Check the presence of the bloody show, whether the membranes have ruptured or still intact. Ruptured membranes increase the risk of infection and usually needs evaluation. And finally, assess their support by asking questions like, who's your support group, or who's your supportive adult in the household, or if the patient is alone. This is good to know because it helps plan for assistance and safety. So just do a thorough phone assessment, which help you determine whether the patient should come to the hospital, stay at home, or just wait. And also, it improves outcome and resources. This slide here outlines nursing care activities during the first stage of labor. Begin with general measures, which include ensuring the patient's comfortable and informed and supported. Through a thorough admission history, this includes reviewing the prenatal records, medical and OB history, allergies, and any risk factors identified during pregnancy. And then review results of routine laboratory tests such as blood show, hemoglobin, hematocrit, and any special tests like group beta B, streptococcus status, and glucose screening. So I hope you're writing all this down. This is the most important thing as far as assessment. When you're there, this is what you need to do when you have your OB patient. Okay, you remember, begin with measures. You want to make sure that they're comfortable, informed, supportive. Look at their admission history, review the medical record, OB, allergies, risk factors. Get their information, routine laboratory like blood type, hemoglobin, hematocrit, and any special tests like Group B, screening, glucose. Okay, write that down, take it to clinic, because this can help you anticipate any potential complications. And it's important to ask about the patient's childbirth plan or birth preferences. This discussion respects the patient autonomy and helps tailor nursing care to their own particular wishes. So such as preference regarding management. So you want to know the management of the pain. What do they prefer? The mobility. Would you like to walk? And their support person. Complete a physical assessment too, okay? Focusing on those vital signs, uterine contractions, cervical dilations, and effacement, fetal position, and even status of membranes. Note that initial contact with the patient may occur by phone or in person, and the thorough documentation is easy regardless of the mode of contact. This slide here just gives you the key components of admission assessment during the first stage of labor. You can take time to read this, but just really begin with that comprehensive maternal history that I was telling you about. It's in your textbook on, I think it's figure 14.13 and box 14.2. It just tells you that, what to review. But this includes past and medical history, OB history, complications, allergies, and medication. Then you'll perform a physical assessment, which includes evaluation of major body symptoms and systems. So check their vital signs carefully, including blood pressure, pulse, respiratory rate, temperature. Also take the lungs and the heart for sounds. Establish a baseline. That's your number one priority. Get a baseline so you can tell if something deviates from that. And then identify any abnormalities. Measure height and weight as they provide important information for medication dosage and assessment of overall health. Assess fundal height to estimate fundal growth and presentation, which can help confirm gestational age and detect any abnormalities or discrepancies. Monitor the uterine contractions or activities by assessing the contraction frequency, duration, and intensity. This helps determine labor progression, and it kind of guides the nurses to any type of interventions. Determine the status of the membranes, whether they're intact or ruptured. If they have rupture, note the color, odor, and time of rupture. And also assess for any type of infection risk. Evaluate cervical dilation and effacement, which are two key indicators of labor progression. Assess fetal heart rate, position, station, to monitor fetal well-being and engagement in birth and canal. Finally, assess the patient's pain level to guide the comfort measures and pain management. This slide continues with the admission assessment, focusing on a fetal assessment, lab studies, and psychological status. So first, conduct a thorough fetal assessment, which includes monitoring the fetal heart rate, evaluation, fetal position, well-being to ensure that the fetus is tolerating labor well. Next, review and order necessary labs, such as urinalysis to check for infection and dehydration, a CBC to assess for anemia and infection. Screening tests include syphilis, hepatitis B, antigen, surface antigen, group streptococcus status, which are critical for preventing neonatal infection. HIV screen is also important, but must be performed with the patient consent, respecting patient autonomy and confidentiality. There is no documented drug screening in the history. I'm sorry, let me repeat. If there is no, like if you notice there's no documented drug history in the electronic medical records, but yet you think the patient is suspicious for substance or drug abuse, then go ahead and order a screening test. Okay, prepare the potential neonate for abstinence syndrome and provide appropriate care as necessary. And then finally, assess the patient's psychological status, including like anxiety levels, coping mechanism, and emotional support needs. Labor can be stressful. It can be a very stressful experience, and understanding the patient's mental and emotional state helps tailor supportive care. Comprehensive assessment, admission assessment, including these components, ensure safety of both the mother and baby while allowing individual care. So we have a question here. If a pregnant patient in labor calls the health care facility, the nurse should strongly advise the patient to come into the facility to be evaluated. Well, we really should know the answer to this already. That's false. Remember, if they call you by phone, um, you really want to ask about their signs and symptoms and what they're experiencing and things like that. That's most important. This slide here highlights the ongoing assessment nurses perform during the first stage of labor to monitor the mother and the fetus closely. Begin by evaluating the patient's knowledge, experience, and expectations about labor. This helps us to tailor education and support to reduce anxiety and promote coping. So, as mentioned before and throughout this chapter, monitor vital signs regularly, including blood pressure, pulse, respiratory rate, temperature to detect early signs of complications such as infection or preeclampsia. Also, as mentioned before, perform a vaginal examination as needed to assess for cervical dilation, effacement, fetal descent. This provides objective data on labor process. Assess uterine contractions by frequency, duration, intensity, either manually or electronic monitoring. Effective communication are essential for labor progression. Evaluate the patient's pain level consistently to guide pain management interventions and comfort measures. Assess coping ability, watch for signs of fatigue, anxiety, any type of anxiety, distress, and provide emotional support as needed. Continuously monitor the fetal heart rate to ensure fetal well being. Observe the amniotic fluid, including its color, odor. Refer to table 14.3 for details. Okay. It even talks about the meconium stain or foul smelling fluid may indicate fetal distress and infections. Ongoing assessment allows the nurse to intervene properly and promptly and also to adjust the care plan as labor progresses. This slide focuses on the assessment of the second stage of labor when the patient is actively pushing and delivering. So first observe for typical signs of the second stage, such as increased contraction intensity and frequency, the patient's urge to push, and visible fetus descent. Monitor contractions frequently. I want you to think about contractions, frequency, contractions, duration, contractions, intensity. So monitor those closely to ensure that they are adequate to support fetal descent and delivery. Regularly checking maternal vital signs, blood pressure, pulse, respiratory rate to detect any maternal distress or complications. Continuously address the fetal rate to the fetal during the fetal heart rate using like an intermittent auscultation or an electronic fetal monitoring to ensure fetal well-being during this critical phase. Observe amniotic fluid again. And finally, coping status of both parent and their partner or support partner um, is important. The second, in the second stage, this can be intensified. This and emotional, and it's a the physical support is essential to promote birth experiences, especially positive birth experiences, one that you will want to remember. Uh, so we have a question. During the second stage of labor, assessment would include which of the following? If you answer A, complaints of rectal or perineal pressure, you are correct. You can read the rationale at the bottom. This slide outlines the key interventions during the second stage of labor when the patient is actively pushing and preparing for delivery. First, nurses support the patient and partner in active decision making. This includes discussing labor progress, pain management options, and interventions that might be necessary. Empowering the patient promotes comfort and control. Encourage the patient to follow involuntary bearing down efforts rather than pushing prematurely. It's important to wait until the patient feels a strong urge or the fetal head has descended and rotated well into the birth canal, which helps prevent exhaustion and trauma with the mother. Please, as nurses, provide clear instructions and assistance during pushing, helping the patient use effective techniques. Offer pain relief measures as needed, whether they are pharmacologic or non pharmacologic. Use maternal positions that enhances fetal descent and reduce pain. Positions such as squatting, hands and knees, or side lying can be helpful to improve comfort. Finally, prepare for assisting with delivery by ensuring all necessary equipment is ready and the team is informed and positioned for safe birth. These interventions are critical to support a positive labor experience and safe delivery for both the mother and the baby. So this slide focuses on nursing interventions during the acute moment of birth in the second um, in the second stage of labor. Begin with cleansing the perineum area and the vulva to maintain a sterile environment and reduce the risk of infection during delivery. Assist with the birth by supporting the newborn as they emerge, ensuring gentle handling and prevent injury. Provide immediate suction of the newborn's airway if necessary to clear secretions and facilitate breathing. Help with umbilical clamping, the umbilical cord clamping, following current guidelines on timing and technique to optimize newborn transition. Provide immediate care of the newborn, starting with drying to prevent heat loss and stimulating breathing. Perform the APGAR score at 1 and 5 minutes apart after birth. So I'm going to repeat that. Perform the APGAR score at 1 and 5 minutes after birth to quickly assess the newborn's heart rate, respiratory effort, muscle tone, reflex response, and color. Ensure proper identification of the newborn to prevent mix ups. This usually includes ID bands matching with the mother and the newborn. This slides cover critical assessment and nursing interventions during the third stage of labor, which is the delivery of the placenta. First, carefully assess for the placenta separation, noting signs of a gush of blood, lengthening of the umbilical cord, and firm, rounded uterus. Examine the placenta and fetal membrane after delivery to ensure that they are complete. Retained fragments can cause postpartum hemorrhage or an infection, so you want to be thorough. Inspect the perineum area for trauma, including episiotomy or laceration, which requires prompt assessment and care. Interventions during this stage include instructing the patient to push gently when the placenta separation is apparent, to aid for explosions. Administer oxytocin as ordered to promote uterine contractions, reduce bleeding, and help the uterus to return to pre pregnancy size. Assist the patient to a comfortable position and provide warmth as they may feel cold or shaky after delivery. And if a episiotomy or laceration are present, apply ice packs to reduce swelling and discomfort. Explain to the patient that upcoming assessment and care helps reduce anxiety, and closely monitor the birthing person's physical status for any signs or symptoms or complications of excessive bleeding or vital sign changes. And record birthing statistics, including birth time, placenta delivery, newborn weight and measurement, and even any other type of relevant data. So, document the entire birthing process thoroughly in the birth book or medical records to ensure continuity of care. This slide addresses nursing management during the fourth stage of labor, the first few hours after delivery when the mother stabilizes physiologically. So some of the key assessments include vital signs to monitor, um, to make sure that they don't have a risk of hemorrhage or infection. So you want to monitor signs for that. Checking the fundus to ensure that it's firm and contracting properly. This helps prevent excessive bleeding. Expect the Inspect the perineal area for swelling, bleeding, and signs of trauma. Assess the patient's overall comfort and pain level. Monitor the lochia, the vaginal discharge, postpartum, the amount, the color, the odor to detect complications. And really evaluating bladder status, because a full bladder can displace the uterus and increase bleeding. Important interventions include providing support and information to help the patient and family understand what is expected during the recovery phase. Um, Performing regular fundal checks and offering prenatal care and hygiene to promote healing and perfection and prevent infection is the best. Assist with and encouraging voiding to empty the bladder fully, implementing comfort measures such as pain relief, positioning, ice pack if needed, facilitating patient newborn attachment by encouraging skin to skin contact and bonding activities. Provide teaching and self care, warning, breastfeeding, and newborn care to prevent um, to prepare the patient for discharge. This stage is vital for identifying complications early and promoting positive postpartum transitions. Thank you.